Okay, well, I think we were due to have a 6 o'clock start, but it's difficult for people to get here, I know. So thank you very much for making the effort to come. I think we'll get underway now, so we'll run things about 15 minutes late on the timing you've got on your handouts. Thank you very much for coming. My name is Dr. Simon Blees. I'm a consultant radiologist and I specialise in musculoskeletal radiology. And it's a great privilege to have been asked to chair this meeting this evening because we are working our way through some new applications that are coming from a new piece of technology. Now, this isn't really tonight to talk so much about the technology because it speaks for itself when you see the images. So there isn't going to be a lot of technical stuff, but it's how we're using this new tool and trying to put it into current clinical problems and areas where we need increased insights. And the Toshiba Aquilion one I'll mention a little bit in the discussion, but there's only a handful of these machines in the country. And they were originally developed to do very fast volumetric CT for cardiac studies and brain studies, brain perfusion studies and the like. But there's very few people trying to push forwards into the musculoskeletal applications. So hopefully the aim of this evening is to introduce the concept of volumetric CT scanning in the musculoskeletal system, and we've assembled a panel of 4 speakers to look at different clinical areas. So this will have very much of a clinical bent. It falls to me to, if you like, kick things off, and I really wanted to introduce this concept for you of what I term functional imaging in musculoskeletal medicine. And look at the new frontiers that we're opening up as a consequence of the access of this scanner. So really I'd like to start by just saying, what do I mean by functional as a radiologist when I'm trying to provide an answer to the requests that are given to me? Most of the musculoskeletal symptoms that we are treating are experienced when the patient's in activity. And this of course means that the patient is often upright with gravity acting in head to foot. Which seems daft then when you look at most of our scanners where the patient's lying down. For me, real-time motion is often very important when I'm trying to get some clear information about what's going on, because there's a very complex interplay between the activators and stabilizers in the joint or in the spine, and either of these areas can be a cause for pain. A specific activity pattern may also be a cause for pain, and I want to try and interrogate the patient when they're doing that action. And also a specific position might be the painful one. So any imaging test I do, I want to try and replicate, why is the patient hurting, rather than just putting them into a default lying down position and image them. So some of the limitations I find with the current techniques that I have available is that you can get overlap of complicated structures, bony overlap, overlying soft tissues and so forth. A lot of the imaging techniques I use may be too slow to capture real-time motion. I can't see all the structures. I have to trade off whether I can see soft tissue or bone. And it's often very difficult to actually use the machines that we've got to put the patient into the position of pain or into a position of load. So this is just, if you like, an overview of the techniques that I currently have when I'm trying to answer a clinical problem. And I'll just go through these by way of introduction before we look at what the CT can do. So conventional X-rays, obviously we've had them around for more than 100 years now, so we understand a lot about what they can do, but of course it's static positioning only. And we get a lot of overlap, bony overlap. We're having to try and tease out a 3-dimensional view from a 2D flat image. I can't see what's happening with the soft tissues unless they've calcified, in which case I can infer there's trouble, but I can't actually see the soft tissues themselves. We can apply artificial stress, like looking at stress views of the ankles and so forth, but that's not really using the primary activators and looking at the joint in its physiological state. And sometimes we can actually add some load, like we can do holding onto a weight and imaging the acromioclavicular joint to see if the joint subluxes, or we can do standing X-rays to look at what's happening to the arches of the feet when we stand. So there is some insights there, but they're not as full as I might want for my purpose. Going to the next level and using screening X-rays is quite good because I can actually now stand the patient up, so I can add the gravity and I can get the patient to move. But I still get a lot of overlap. I'm still looking effectively at a 2D image, and I still can't see my soft tissues. CT is great because it's taking the X-ray and rotating it around the patient, so I'm automatically getting rid of overlap straight away. But again, because the patient's lying down on a table, I don't weight load the patient necessarily, and it's difficult to get true physiological motion again. And with a CT scanner where I'm rotating the X-ray tube, I have to move the patient on the table through the hole in order to be able to build up the CT image. So they have to lie still. If they don't, we can get misregistration in the images. I can, however, continually image a thin slice, in a repeat loop. But of course, then I've got a very small coverage. So I'm still struggling to get a real answer. Now, ultrasound is great because we've got real-time capability here. It's scanning all the time, and I can put it over the area of interest and get the patient to move it and try and see what's going on. I can scan them whilst they're in pain or in a stress maneuver, and I can get additional functional information, and also I can use it to direct therapy. I can see where I'm putting the needle, for example, into the subacromial bursa if the patient's got a painful shoulder. My real problem again, though, is that I'm limited to the soft tissue structures this time rather than bone. The ultrasound can't penetrate through bone. Also, it can only penetrate a certain distance through soft tissues themselves. So getting in-depth penetration in large soft tissue structures like the spine or the thigh or the pelvis can often be very difficult. And I'm stuck with that limited field of view, which is as big as the probe head. There is a lot of intellectual challenge to being able to correlate what the ultrasound is showing you with the physical state of the patient underneath you. I often call ultrasound an extension of the examining hand, and that's because I've had a lot of training. And when you train someone in ultrasound as a clinician, they often will get it. But there is an intellectual challenge there, and there's a technical challenge as well to be able to scan properly. And if you're trying to, say, scan a shoulder whilst the patient's doing that, you'll find it's difficult because the probe head will be kicked off by the motion. So maintaining that skin contact can often be very challenging. So it might sound easy, but actually when you try it, there's a few hurdles to overcome before you can be successful at it. And by way of illustration, I've just put a couple of little AVIs here. Now, just so that to orientate you, this was a protocol I was using to look at causes of groin pain. Now, this is the patient's head end here, feet down here. And what you're looking at here, this is the anterior border of the symphysis pubis. This is the rectus abdominis musculature coming down to insert over the front of the symphysis pubis here. And we're down into the thighs down here, and this is the peritoneal cavity at the bottom. So at first I was looking at herniae coming through slightly more laterally, but this is close to the midline. And it was interesting when I got the patient to cough and just watch what's happened to the symphysis pubis here. It doesn't move hardly at all. Now, that is a normal patient with normal pelvic stability. So again, if you watch when they cough, keeping your eye on the front of the symphysis there, there's hardly any deflection at all. That's a coughing maneuver, which I'd adapted from looking for a hernia coming out. This is a patient who had known poor core stability, and we asked them to do the cough maneuver without turning their core stabilizers on. Again, so you're orientated, that's the anterior border of the symphysis pubis, the rectus abdominis muscle coming over to the front of the symphysis there. Watch that area there as I play the video as they cough this time. This is a patient. Okay, fine, that's interesting. What's going on there? And I got really interested in this because I did a lot of work with groins and trying to find out why these patients develop these tears that seem to come from the front of the symphysis by the pubic tubercle going back into the inguinal canal. And maybe this is a bowstringing concept. Maybe patients who have poor pelvic stability are constantly overstressing that common adductor and rectus aponeurosis over the front of the pelvis and starting to peel off from the front of the pelvis. So you can see how using something like ultrasound here is helping me to gain, if you like, a little bit of a functional insight into why patients are generating these pathological lesions that the surgeons later go in and repair. But as you can see, I can't see through bone. It's a pretty sort of low-res image. You have to believe me when I tell you what you're looking at, but it could be anything, couldn't it? Okay, so, you know, it's a big intellectual challenge. So really, I'd like a better test than that, please, if there is one. Well, MRI is great, because it shows me both soft tissue and bone with equal capability. So for me, as a sort of, if you like, an applied anatomist, the anatomical detail I get is great, and that's what I love about it. The big negative is it's slow. We're still taking 1 or 2 minutes, even with the fastest scanners, to acquire an image set. And some people have tried to do things like patella tracking using so-called kinematic, where you image for a second, then move, image for another second, then move, and then putting into a cine loop. As far as I'm concerned, it's worse than useless, because you haven't got physiological movement. You haven't got all the muscles pulling in concert in that coordinated fashion in true real-time movement. And so I don't think that the information you get from that is reliable. Once again, for most MRI scanners, the patient's got to lie down, and you can't really scan them in a position of pain. You can try. This is what I call the abducted externally rotated position, or the stop sign, which a lot of patients get, particularly in the overarm throwing athletes or in the javelin throws you see there, where they get that sudden catch of pain when in the shoulder. So sometimes using an open MRI scanner, I can put the patients into this so-called APA position, and that's the imaging coil, and they're about to slide into the scanner there to look a little bit more functionally in terms of position at least at what's going on. This is a wonderful medieval torture device. This is a patient where we're trying to get weight loading on the spine in a patient who's lying recumbent. And this corset device attaches underneath the imaging coil there, and these straps come down to this foot plate here, and you've got these 2 little dials, and you can dial in tension on these bands that pull down on the patient's shoulder to replicate standing. And you say to the patient, I'm going to turn these dials until it hurts, sort of thing, which is kind of nice. And then they have to lie there with the pain for about 5 minutes whilst we try and get a scan. Of course, they can easily just bend their knees to get rid of the tension. But, again, it's medieval. It's not particularly physiological, and we struggle to get to anything like the normal situation. Going a little bit further, we can actually, some MR machines can scan the patient standing up. This is the Phonar upright scanner, but as you can see, it's absolutely humongous. It's very slow, it's very large, it's very challenging to run, actually, to get good images. But you can see the ends to which we will go to try and get some true physiological imaging in patients. So, what comes next? Well, what the purpose of the presentation this evening is to introduce you to the concept of dynamic three-dimensional volume CT scanning. Now, as I mentioned earlier on, initially the first generation of CT scanners, you had an X-ray tube rotating around the patient, so you'd generate a single cross-sectional slice in one rotation of the tube. Then someone had the bright idea, well, what happens if you continually rotate that X-ray tube, but then motor the table through that rotating tube? Well, of course, you end up with a spiral acquisition, so-called spiral CT, and you could feed all that information into a computer and it kind of work out the misregistration that was occurring and give you a volume, but there was lots of so-called stepping artifacts that were low-res imaging. So people started saying, well, let's do a helical scan or a spiral scan, not with just one slice being acquired, but several at the same time. And that threw us into something that I call slice wars, as manufacturers vied with it to say, well, hey, I can scan 4 slices at a time, and said, well, no, I can do 16 at a time. And so it went until we got to the 128 generation scanners, which were, until the Aquilian 1, the state of the art. Toshiba then introduced this 320 slice machine, so they're acquiring 320 slices of data simultaneously as the patient is being moved through the machine. But suddenly, if you think about it, 320 slices is quite a big volume of tissue. And in fact, what it allowed you to do is to disengage from this so-called slice paradigm to something I like to talk about, a volume paradigm. In other words, we're not imaging multiple slices stacked up. We're actually imaging a whole volume. Now, why is this important? It's important because it gives you the idea that you can actually now start to do three-dimensional X-ray fluoroscopy. Effectively, what you're seeing is that 320 slices represents a 16 centimeter deep cylinder of tissue that you can image in real time, or effectively every 0.35 seconds, which is the refresh time, the time it takes to do one rotation of the gantry to collect all that data. That's 320 slices of data being fed into the computer. Therefore, the table does not have to move. And that's an important concept, because suddenly it means that instead of artificial movement of the table, you can start to use controlled movement of the body part within that imaging volume, and that releases you from the restrictions that are placed on most scanners. It allows you to think about recreating painful maneuvers. You can try and get the patient into the scanner in a way that they're getting some kind of gravity loading on some body parts. And